Welcome to the Global HIV Clinical Forum 2020 Optimizing Treatment. My name is Jonathan Shapiro. I'm from the National Hemophilia Center at Sheba Medical Center in Israel. And on behalf of my co-chair, Charles Boucher from Erasmus Medical Center in the Netherlands, we're delighted to have you joining us. This will be a two-day program. Each day will be 3.5 hours. And depending where you'll be viewing it around the globe, this will be either morning, afternoon, evening, or night. But you'll be able to view this after the program at any time that's convenient for you. We have detailed learning objectives, which focus on learning and understanding new treatment and new treatment strategies. And we invite you to read these in detail on the website. But the bottom line is very simple. Our objective and goal is to improve our clinical care of people living with HIV. And to that end, we've assembled an absolutely spectacular cast of faculty who will be giving plenary talks, case presentations, and live roundtable discussions over the next 2 days on topics of their expertise. We are CME accredited, and those who'd like to claim credit can do so on the website. And I'd also like to thank our sponsor, ViiV Healthcare, who provided an independent educational grant. The sponsor was not involved in any way in the development of the program or the decision on speakers. Our first day will have 2 sessions. One, state-of-the-art lectures, update on clinical trials and their significance for patient management. And our second session will be on reduced drug regimens, scientific considerations. If you have questions, we'd be delighted for you to submit them. You have a Q&A window in Zoom, and we'll do the best to answer them either directly after each talk or during the roundtable discussion. I'm not sure we'll be able to get to all of them, but we'll do our best. So our first session, state-of-the-art lectures, update on clinical trials and their significance for patient management, will be chaired by Dan Kuritzkes. Dan Kuritzkes will also be our first speaker, and he comes to us from Brigham and Women's Hospital and the Harvard Medical School. And with that, I'll hand it over to Dan.
Hello, I'm Dr. Daniel Kuritzkes from Brigham and Women's Hospital and Harvard Medical School in Boston. It's my pleasure to be giving this keynote lecture for today's program. I'm going to be speaking about COVID-19 in persons with HIV infection. This slide shows my disclosures. As we're all painfully aware, the pandemic of COVID-19 has truly become a global problem. As this slide shows, although early in the beginning of the year, the pandemic was focused in Wuhan, China, it has since become truly global in extent, covering all of the United States, making significant inroads into South America, the Indian subcontinent, parts of Africa, and of course, across Europe. What's important to note is that many of these regions are now regions where the HIV epidemic, itself a pandemic, is also highly prevalent. And so the intersection of COVID-19 and HIV is of considerable concern. As of the time that I pulled these data, there were nearly 9.4 million cases of COVID-19 reported worldwide and just under 500,000 deaths. There are many topics that one could speak about, but in the short time that we have today, I'm going to cover 3 specific areas related to the overlap of COVID-19 and HIV. What is the impact of HIV infection on the risk for COVID-19, both in terms of the risk for acquisition and the outcome for those who do become infected with SARS-CoV-2, the agent of COVID-19? What effect, if any, does antiretroviral therapy have on SARS-CoV-2 infection? And what is the syndemic impact of the intersection of these 2 pandemics? So let's start with the first topic. Does HIV infection increase the risk of acquiring COVID-19? We know in the setting of other respiratory illnesses, such as influenza, there's really a variable impact of HIV infection. We've seen data published that show that there is a higher risk of hospitalization and worse outcome in children and persons in lower and middle income countries, particularly those with significant immunodeficiency who have HIV infection and outcomes with influenza. But the impact of HIV and influenza in adults and in those from upper income countries has been much more mixed, and there's really no compelling evidence that influenza outcomes are any worse in that setting. To date, there have really been minimal data on the impact of HIV on COVID-19. Anecdotal experience suggests that persons with HIV are not overrepresented among patients with COVID-19. These data, which report the experience with 5,700 patients with COVID-19 in the New York City area. These are mostly from the suburbs immediately outside of New York City proper. So this is really from Nassau and Suffolk County on Long Island, for those of you familiar with the geography. You can see that of these 5,700 persons, only 43 or 0.8% had HIV infection as well, representing a tiny fraction of those with COVID-19. If we look at outcomes of COVID-19 in persons with HIV infection, to date there have been no large prospective systemic analyses of outcomes of COVID-19 in HIV-infected individuals. There have been a number of small retrospective studies, many of which are really still available only in preprint format, so they haven't been peer-reviewed and formally published, suggest no adverse effect of HIV on outcomes with COVID-19. This study, published by Carmen Tui et al., posted because it's just in medRxiv, not yet officially published, looked at hospital outcomes among patients with COVID-19 who did or did not have HIV infection. This is a relatively small study of only 63 persons. You can see that by and large there was really no difference, whether looking at length of stay, the requirement for supplemental oxygen, the number who needed transfer to intensive care units, and the like. The only significant differences that emerge were somewhat higher C-reactive protein levels among those with HIV infection, and actually a somewhat higher abnormal chest X-rays in that group as well. Another study from this one from Madrid that's received some attention, this has actually been published in Lancet HIV, examined the characteristics of persons with HIV infection with or without COVID-19. So the previous study compared COVID outcomes in those with and without HIV. Now we're looking at HIV-infected persons with and without COVID. This was a single center study, also relatively small numbers of people with COVID, and no difference in outcome was seen between those with and without HIV infection, and they made the point that comorbidities were high among patients who did have a HIV infection. So they started with nearly 3,000 HIV-infected persons, of whom 51 had COVID-19, and nearly 1,300 had no COVID-19. Of those 51, 23 eventually recovered. There were 2 who died after admission to hospital. 21 of the 28 who were admitted to hospital had recovered, and at the time of publication, there were still 5 people who remained hospitalized. If you look at outcomes as a function of baseline CD4 count, or CD4 at the time of diagnosis, you can see that here the green bars represent HIV-infected individuals without COVID-19. The red bars are HIV-infected persons with COVID-19. And there's really no difference in the proportion for those who had low CD4 counts, whether they did or didn't acquire a COVID-19, or for those with intermediate or higher CD4 counts, maybe a slightly greater proportion of people with COVID and higher CD4s, but that's not a significant difference, and the numbers are really quite small. And then if we look at those who were critically ill, there were perhaps slightly more critically ill people at the very low CD4 count stratum, but again, with very small numbers. Let's talk now about antiretroviral therapy and COVID-19. There's been a great deal of interest in whether any antiretroviral drugs, particularly the protease inhibitors, might have activity against SARS-CoV-2. There were some data based on in vitro observations that lopinavir, despite being an aspartyl acid protease inhibitor, could inhibit the SARS-CoV-2 proteases, which are cysteine proteases. And you can see from this panel here that there's modest in vitro activity with an EC50 of just under 12 micromolar, which is about at the border of what kinds of plasma concentrations can be achieved with dosing of boosted lopinavir. In addition, there were retrospective case control series from the original SARS epidemic, SARS-CoV-1 as we now call it, suggesting a possible benefit of boosted lopinavir. However, a randomized clinical trial of lopinavir ritonavir conducted in Wuhan in patients with severe COVID-19 failed to demonstrate any clinical benefit, as shown in the lower panel here from this randomized clinical trial published in the New England Journal of Medicine. In addition, darunavir has no activity at all against SARS-CoV-2 in the laboratory. You can see the positive control remdesivir has activity at nanomolar concentrations, whether assessed by a visual readout or by intravital dye, whereas there's absolutely no inhibition observed with darunavir. There are also some question about whether nucleoside analogs may have activity against SARS-CoV-2, and some of the drugs have shown in vitro activity, but there are really no clinical data to suggest that there is a benefit, and certainly no evidence that individuals who are taking nucleoside reverse transcriptase inhibitors as part of an antiretroviral regimen or as part of a PrEP regimen have any different risk of acquiring COVID-19 or any difference in the outcome of COVID-19 infection. Well, let's spend just a couple of minutes now talking about the syndemic impact of co-pandemics of HIV and COVID-19. There's tremendous potential for the pandemic of COVID-19 to disrupt healthcare infrastructure and therefore interfere with healthcare delivery for people with HIV. This can include supply chain interruptions, not just of medications, but even of the ability to do laboratory monitoring. For example, in the United States, so much laboratory infrastructure is given over to testing for SARS-CoV-2 that there have been significant delays in the turnaround time for reporting of HIV virus load tests. In addition, public health infrastructure has been stretched to the limit with significant diversion of resources that should be used for HIV prevention now being used to track and prevent the spread of COVID-19. Populations most at risk for HIV, that include minority populations in North America and throughout the world, those who are economically disadvantaged, and other populations at risk are also the same populations that have the greatest risk for COVID-19. And then we know that in many respects, because of the same economic forces at work and the history of discrimination, that comorbidities such as cardiovascular disease, hypertension, diabetes, obesity, and the like are highly prevalent among persons with HIV, and this also predisposes to more severe COVID-19. So the DHHS guidelines panel, the antiretroviral treatment guidelines panel, has come up with a number of points for consideration and to guide the management of people with HIV in the setting of the COVID-19 pandemic. First of all, they reiterate that individuals aged over 60 years of age, those with diabetes, hypertension, cardiovascular, and pulmonary disease or obesity are at the highest risk of life-threatening COVID-19, whether or not they have HIV infection. The limited data currently available do not indicate that the disease course of COVID-19 is modified in any way in those with HIV compared to people without HIV. Comorbidities prevalent among some people with HIV, as I mentioned previously, including cardiovascular disease and lung disease, increase the risk for more severe outcomes with COVID-19. And chronic smokers are also at greater risk for more severe COVID-19. And we know that in many countries, the prevalence of smoking is much higher among people with HIV infection. Until more is known, the guidelines panel recommends caution for all persons with HIV, especially those who have advanced HIV disease with low CD4 counts or poorly controlled HIV. Every effort should be made to help persons with HIV maintain an adequate supply of antiretroviral therapy at home in order to guard against potential stockouts and supply chain disruptions. And the one thing we can certainly do is to ensure that our patients with HIV infection have their vaccinations for influenza and pneumococcal disease kept up to date. With regard to protecting against stockouts, it's recommended that patients maintain on hand at least a 30-day supply and ideally a 90-day or 3-month supply of antiretroviral drugs. They should talk with their pharmacists or healthcare providers about changing to mail order delivery of medications in those settings where that is possible. Persons for whom a regimen switch is planned should probably consider delaying that switch if there's any consideration that monitoring outcome following the switch might not be possible, either because clinic visits are being deferred or because testing is taking longer than ideal. And as I reviewed briefly to date, no antiretroviral drugs have been proven to be safe and effective for the treatment of COVID-19. Therefore, persons with HIV should not switch their antiretroviral regimens or add additional antiretroviral drugs to their regimen for the purpose of preventing or treating SARS-CoV-2 infection. So thank you very much for your attention, and now let's turn to the rest of our program.
Great, Dan, thank you very much. That was an excellent and comprehensive overview of COVID-19 HIV-infected patients. These days, data emerged so quickly, I wanted to ask you if there was any recent updates which came up on the impact of HIV on the severity of COVID-19.
Yeah, you know, it's just extraordinary. In just the last few days, there have been 2 important papers, one that was published in the Annals of Internal Medicine from the group in Spain, and one published in Journal of Infectious Disease from the group in the Mount Sinai Health System in New York City. The Spanish study, which included centers from across the country and over nearly 80,000 patients with HIV infection, had about 240 people who developed COVID-19. Curiously, in that study, they did see that there seemed to be less severe outcomes in people who received the TDF formulation of tenofovir compared to other regimens, notably in comparison to TAF. Remember that there are higher levels of tenofovir with TDF than with TAF, but that's a finding that clearly requires confirmation, because in the Mount Sinai study, which likewise had several hundred people with HIV, they found that there was really no difference with a tenofovir containing regimen or not, but they didn't tease out whether it was TDF or TAF. Neither study showed overall any worse outcomes for people with HIV than those without, but clearly a lot more to learn.
Yes, I think there was a study which was started in Spain and now has moved to Africa, actually trying to use tenofovir for prevention. I don't think they have any results, but I remember that was started and is hopefully moving forward.
That's right. We'll have to see what the results of that study are.
Wonderful, Dan. So we'll thank you and we'll allow you to take us to the next talk.
Sure, that's great. Thanks very much, Jonathan. Well, it's my pleasure to introduce our next speaker, Dr. David Wohl. Dr. Wohl is a professor of medicine in the Division of Infectious Diseases at the University of North Carolina in Chapel Hill. He is an expert on HIV treatment and its complications. He's been a past member of the U.S. Antiretroviral Guidelines panel. He has a lot of experience outside HIV as well, having been involved in helping to deal with the Ebola outbreak in Liberia from several years ago. And this year, he's been helping UNC lead its clinical and research response to COVID-19 and is the vice chair of 2 AIDS clinical trials group studies of treatment for SARS-CoV-2. David is going to be talking to us today about choices for first-line antiretroviral therapy. So I'll turn this over now to Dr. Wohl.
Thank you very much, and thanks for your attention to this important topic. We're going to be talking about first-line therapy for HIV infection, and I'm David Wohl, as you know. So I think in thinking about initial therapy for HIV, for me, I like analogies, and an analogy that I think is apropos is when we're starting someone on HIV therapy, I think of it as planting a seed, and all the things we need to do that to ultimately get to a healthy plant. And so there's many steps, and when you read how to fundamentally plant a plant, you can think very much along the same lines when we think about how to initiate HIV therapy that's going to be successful, that's going to grow into a person's life and be integrated into their existence. And some of the very fundamental steps, I think, help us in preparing not just which antiviral we should use, but how to use it the right way. So when we plant a plant, we select quality seeds. We could plant the seeds in fertile and prepared soil. And then you're not done. You need to provide light, and you need to provide water, and make sure there's no pests or any threats. And much like in HIV therapy, we need to do the same thing. We need to select quality medicines, and we need to prescribe good medicines to a prepared patient, someone who's willing and able and supported in taking their HIV therapy. And then again, you're not done just by selecting the right medicine and having a motivated person. People's lives can be complicated. As we know recently, there's lots of challenges with staying on medicine and taking care of oneself and engaging in care. And so trying to support people through what may be lifelong therapy is really important. And so stacking the odds in their favor. And so for me, the two are very much alike. And I think of this constantly, especially this prepared soil, because we do have good medicines and we do have good programs for keeping people on their medicines. But I think the most integral part of this is really the fundamental substance of the individual. And are they willing, able, ready, and empowered to start medication? In fact, we know that when people do start medicines, they do a really good job. And people have seen these continuum of care slides, and this is one of the more recent ones, and this is global, looking at people with HIV and how many are living with HIV worldwide and are aware of their status and on treatment, and then ultimately how many are virologically suppressed. And while this cascade is concerning because we'd like to see all the bars pretty high across the spectrum, when you look at the end bars, the last bars on the right, the drop-off is much less compared to the other parts of the cascade, meaning that most people on therapy, the overwhelming majority, achieve virologic suppression. And so we know that once we can get people on therapy, they take it. And not only do they take it, but they take it successfully. And so this is a real testament to this prepared soil, to the prepared patient, using good drugs in people who are empowered to take their medicines. So we have a lot of different HIV medicines. There's charts like this that have multiple colors and multiple classes with multiple pills and other things now that we're using to treat HIV. And deciding amongst these different therapies is a challenge, especially for those who are newer to HIV therapy. And the good news is we have guidance, and the guidance that we have is fairly consistent. So here in the United States, we have guidelines for the use of HIV therapies and people starting therapy for adults and adolescents, as well as for children and pregnant women, as we'll go over in a second. And so I think this guidance provides us with a roadmap for how we should be thinking about things. And I'll go through them in a second. The other thing is that there are guidelines from other places outside the United States, and I think those are important to pay attention to as well, because there could be different considerations depending upon where you are geographically. So how do we choose? Lots of different choices. There's a lot of medicines that have been developed over time. There's some older medicines, some newer medicines, and some in between. And so how do we choose among them? Is newer always better? Are there some advantages of one class versus another? So not only do we have to think about classes of medicines, but we also have to think about individual medicines within each class. Looking at the Department of Health and Human Services guidelines and also the IAS-USA guidelines, both of which are paid attention to in the United States, although arguably I'd say that the Department of Health and Human Services guidelines people pay a little bit more attention to, and I think that's because they're constantly updated. So it's a very dynamic document. It's not something that's just published intermittently. It's a website where people can get updates. So I think a lot of folks look to that panel for guidance, not only here in the United States, but worldwide. And just comparing, they're pretty similar in broad strokes. Both guidelines recommend that we use options that are going to be, of course, most effective and better tolerated. And this is something that's been developed for many years and refined over time. But both guideline panels of what kind of choices are available. When we look at the Department of Health and Human Services, the initial regimens for most people are listed here. And just to point it out, so we see bictegravir, TAF, FTC, followed by dolutegravir, bacavir, 3-TC if someone's HLA-B5701 negative. Dolutegravir can be used also with tenofovir, whether it be TAF or TDF, again with 3-TC or FTC. Raltegravir is another integrase inhibitor. So far we've only been talking about integrase inhibitors, and you're going to see that's a theme here. Raltegravir, again, with TAF or TDF or FTC and 3-TC. And then more recently, the addition of dolutegravir 3-TC, a 2-drug regimen, with some caveats. So except in individuals who have a higher viral load above 500,000, there's not too many people like that, or who are co-infected with hepatitis B because there's not fully active agents against hepatitis B as opposed to what we see with TDF or TAF. And again, worried a little bit about genotypic resistance maybe, and some transmitted resistance possibly to the 3-TC, which is not very common but can occur. So maybe not using this as a rapid start. The IAS-USA, again, reflects the same sort of preference for integrase-based regimens. Here, not jumping into the 2-drug therapy just yet, but again, bictegravir, TAF, FTC, dolutegravir, bacavir, 3-TC, or dolutegravir, TAF, FTC. Really a little bit more hedging towards the TAF versus TDF in the IAS-USA guidelines. But overall, despite some of those differences, most of these guidelines really do overlap tremendously, and it doesn't have to be completely concordant. But I think you can see, again, integrase inhibitor, especially newer integrase inhibitors, along with a tenofovir delivery product or a bacavir. So what about in Europe and other parts of the world? The EAKS guidelines are also really well thought out and beautifully presented in their guidelines. And very similarly, preferred are 2 nucleosides and integrase. And you can see them here for yourself. It really reflects very closely what we saw with the DHHS guidelines, maybe a little bit different here in some of the wording, but really the same sort of general concept. And then everything else considered as an alternative, certainly recommended, but in certain circumstances, including dolutegravir 3-TC here. And then even getting into some of the NNRTI or PI-based regimens. But again, I think preferred among the recommended regimens, there's a little parsing of terminology here, are these integrase-based regimens. In pregnancy, I think things have to be a little bit different given the data that we have. And really the operative point here is that we really overall need to just maintain virologic suppression. That's the most important thing. We could quibble about category of what antiretroviral is as far as pregnancy, but women should be on regimens that they can tolerate and that suppress their viral load. And there should be really very few examples where medicine is not appropriate at all for a woman who's pregnant if she's tolerating and virologically suppressed. And we do want to start HIV therapy as early as possible if HIV infection is detected during pregnancy, or we have a pregnant woman who's not on HIV therapy. And the preferred regimens are listed here, breaking it up into the NRTIs, either bacavir 3-TC, TDF FTC, or TDF 3-TC. As you can see, TAF is not recommended in the DHHS guidelines for women who are pregnant. That doesn't mean that if a woman comes in on TAF, she couldn't stay on it if that's what she wanted to do, but there's just not as much data on TAF in pregnancy, not so much that it's a concern that it is toxic. Integrase inhibitors are again preferred. Raltegravir, there's more data in pregnancy. Dolutegravir is an alternative, and there were concerns and still are about neural tube defects with dolutegravir in pregnancy based upon a very well-conducted study in Botswana. Over time, that signal seems to have dissipated somewhat, and so I think there's less concern about that, and the advantages of dolutegravir in pregnancy really seem to outweigh any of these potential risks. And then for people who can't take an integrase for one reason or another, there are boosted PIs, including atazanavir and darunavir, for which there are more data. We don't use cobicistat, and for here, there's a really good reason. It's not so much that there's not data, but that cobicistat doesn't boost the PIs as much as ritonavir does. And so this is, this is a concern for pharmacokinetics, and we want to make sure there's enough PI available, and ritonavir delivers a higher PI level than cobicistat does due to volume of distribution. So what this comes down to for most of us is going to be one of these four choices. We're going to either use BF-TAF or dolutegravir, either with TAF-FTC or bacavir 3-TC, or dolutegravir with 3-TC as a 2-drug regimen. And there are data to support all of these. So what these guidelines do is basically, you know, football matches between different regimens. We look at the trial data, and you can see here in this study on the bottom left, here's BF-TAF versus dolutegravir, bacavir 3-TC head-to-head. And in this boxing match, it was a draw. So that's great. You know, high proportion of people, even at week 144, having a virologically suppressed, you know, result. Same sort of thing here when comparing TAF-FTC and dolutegravir versus BF-TAF, or even with the 2-drug therapy of dolutegravir 3-TC versus dolutegravir plus TDF-FTC. Again, we're starting to see numbers in the upper 80s to 90s of virologically suppressed people at whatever time point you're looking at. So the guidelines reflect really good clinical trial data, safety data, and less cost, so that they're really, maybe that's something that's growing over time, but certainly are looking at efficacy and tolerability, and even convenience. So a single drug, you know, single tablet regimen might be somewhat more preferred than a multi-tablet regimen, dosing during the day, but operatively, it's really going to be efficacy and tolerability. In all of the studies of all the regimens that I've listed up here, there's been no treatment emergent drug resistance. And that, I think, is a really other defining point. These are regimens which we're not seeing people develop resistance to. There are alternative regimens that work really well, that are really well tolerated, and as we'll point out in a second, don't share that feature, where failure, if it does occur, even though it doesn't occur frequently, can occur with resistance. So another selling point, if you will, of these regimens that are listed here are that they're really sort of bulletproof to resistance. So what about concerns? What's the downside? So like in our analogy, you know, there can certainly be the fertile soil, there could be the great, you know, seeds, and you give it plenty of sunlight and water, but then along comes some pesky problem. And here with the integrase inhibitors, the pesky problem that we're worried about more recently is weight gain. And this advanced trial, which I think really made it very clear that there are some differences between regimens when we're starting people on HIV therapy as far as weight gain goes, is something that I think we should pay attention to and just look at it a little bit more carefully. This is a study that was done in South Africa, and it took over 1,050 participants and randomized them to the regimens that are seen here. Efavirenz TDF-FTC, which has been pretty much the standard go-to initial therapy in that part of the world, versus dolutegravir TDF-FTC, which is becoming more dominant, or dolutegravir TAF-FTC. So people were randomized. This is initial therapy. And this kind of gets at some of the issue of, well, everyone's going to gain weight because they're starting HIV therapy, but are there differences between the different regimens as far as the weight that is gained? And you can see here a really clear stratification, such that people in the green on efavirenz TDF-FTC certainly gained weight. We know that when people start HIV therapy, there could be this return to health where people feel better. Maybe they're metabolically less energized to fight the virus. Whatever's going on, they gain some pounds. Here you can see they did gain some weight, but much more weight was gained when you had TDF-FTC dolutegravir instead of the efavirenz, now dolutegravir, and substantially more weight when we're talking about TAF-FTC dolutegravir. And this was much more profound for women than it was for men. So we see this stepwise increase for men, but it's even 2 kilos more on average for women. And when you look at, thresholds for treatment emergent obesity, so a BMI of 30 plus, the proportion of women who developed on treatment obesity was very high and certainly higher than the men. So this is a real concern. And when we see it again stratified by therapy, TAF-FTC dolutegravir was much more of a culprit than the TDF-FTC dolutegravir and the TDF-FTC efavirenz. Now, the reasons for this are a little unclear. We don't completely understand what's going on here, and there's some thought that maybe TDF itself may prevent weight gain. Maybe it causes a little bit of an anorexic effect. It's not clear whether or not TAF inherently helps people gain weight. There are data that come from HIV-negative people taking TDF or TAF for PrEP, where we do see some differences, but that doesn't answer the question either, because again, TDF inherently leads to less weight gain. Is it really the TDF or is it the TAF? What's going on here? And it could be a little bit of both. But right now, regardless of the reason, if you treat somebody with these regimens, this is what you can expect to see in a population such as this. Other analyses have looked at broadly different regimens, and this is a nice one that was published in Clinical Infectious Diseases, looking at a bunch of different clinical trials that compared very different regimens, most of them integrase or NNRTI. And you can see, trying to color code this, the purple are integrase anchors versus the orange, which is the NNRTI. And even one of the trials included a boosted PI. And when we look stratifying by different groups and looking at weight gain and change in weight, we see a very similar pattern. And just to dissect this out, what we can see most importantly is, again, this TAF versus TDF, more weight gain over time in people on TAF versus TDF. In between was abacavir, which is kind of interesting. It looks like abacavir kind of overlaps mostly with what we see with TDF, but TAF certainly more weight gain compared to the other two. Like we saw in the study from South Africa, women much more than men, and it does look like women of color, Black women specifically, and Black men compared to non-Black men and women, we see more weight gain there, which is also something that we have to think about. And then this is the first study or analysis that really looked at bictegravir to see whether or not it's any different than dolutegravir, and the data indicate that they behave very similarly, not only in efficacy and tolerability, but also in weight gain. Elvitegravir, cobicistat, which was in these trials, many of these trials seem to lead to less of a weight gain than the newer integrase inhibitors. What about dolutegravir 3-TC? Does that cause weight gain? That doesn't have TDF or TAF in it. And we only have a little bit of data from the Gemini trials. Those are the studies that showed that dolutegravir 3-TC was efficacious compared to a TDF, FTC dolutegravir regimen. Again, this is a little complicated because if TDF makes you not gain as much weight, we're comparing that to something that doesn't have TDF. And overall, what we saw in this trial was that in the dolutegravir 3-TC group, there was a little bit more weight gain compared to the group that had TDF on board. And that, again, may not be too surprising. So it may be that dolutegravir 3-TC also, we can expect more weight gain than what you would see with a TDF-containing regimen. If TAF was compared here, you can imagine that it might be very similar to this or maybe a little bit higher. We just don't have that arm in this particular study. In their supplement to their paper, they broke this out by how many people or what proportion of people went from normal to overweight or obese. And you can see it's pretty flat, but more people in the 2-drug arm, you can see in the bluish color, generally went to obese or overweight depending upon what they started at baseline. So again, there's going to be a little bit more weight gain than with dolutegravir 3-TC than maybe our TDF-FTC regimens that we had used previously. What about other drugs and what do they do? Are there alternatives to the integrase inhibitors? Doravirine is a newer NNRTI. It has pretty good efficacy for sure and good tolerability. This is one of those NNRTIs though, of course, and so their barrier to resistance is lower in some people who do fail with doravirine, although it's not a lot of folks, do fail with resistance. And so makes it a little bit less attractive compared to some of the integrase inhibitors. But when weight gain or the potential for weight gain is a problem, maybe doravirine is an alternative. And we do have some data from the trials of doravirine in treatment-naive folks that show that compared to efavirenz, there might be, again, a little bit more weight gain, but this is on par with what we see in most studies that don't include these newer integrase inhibitors. So much lower amounts of proportion change of weight gain, both in kilograms and the mean change. So I think this is maybe an alternative. It's certainly someone who comes in who is really concerned about weight gain. This might be something to opt for. Whether or not switching someone from an integrase inhibitor to doravirine would lower their weight is not clear. There's anecdotal reports that does occur, but I think we'll see more data coming about this soon. But again, I would put this out there as maybe an attractive alternative so that you don't have to use a boosted PI and you can use an NNRTI that's pretty efficacious and well tolerated, albeit with some risk of resistance if a person doesn't take the medication as directed. Lastly, I think I mentioned this before, guidelines don't really pay that much attention yet to cost, but I think that may be something we have to think about, especially in the current economic climate. And there's been some really nice analyses, including this one, that show that recommended regimens generally are more expensive than the alternatives, and that the cost of these regimens is increasing over time linearly. And you can see for yourself just different categories of some of the medications by class and also by specific agents and combinations and just what their costs are. So some of those that we've been talking about as being recommended are also, maybe not coincidentally, the most expensive. And of course, pricing is complicated, and what one person pays in one place may be very different than another person and what they pay in another place. But I do think that this is something that may also influence what we choose among our patients. So putting this all together, again, I think for treating HIV for initial therapy, newer integrase inhibitors are preferred, and that means dolutegravir or bictegravir. Raltegravir has a lower barrier to resistance than the newer integrase inhibitors, and again, well tolerated, but that's something that I am a little concerned about. And so there's fewer instances where I would go for raltegravir compared to dolutegravir or bictegravir. For bictegravir and dolutegravir, again, high barrier to resistance, well tolerated. We didn't talk much about this, but drug interactions are rare, and I think that's another selling point. And then bictegravir certainly and dolutegravir come in single tablet regimens, depending upon what they're coupled with. Cautions are the weight gain, and we talked about the neural tube defect risk, and that's something to at least talk to people about and do some shared decision making in women who could become pregnant or who are pregnant. But again, the data are indicating that that's probably not a significant risk, and the benefits of these drugs probably outweigh that risk. NNRTIs are important, and doravirine is a nice new addition, but they do have a lower barrier to resistance, and there may be less weight gain with them, and that may make them an important factor as an alternative to these newer integrase inhibitors. I didn't talk much about PIs, and that's intentional. I think protease inhibitors have had their day. I'm thinking that there's very few people who need to start on a boosted protease inhibitor. There's major drug interactions due to the boosters of cobicistat and ritonavir, generally more side effects, and in most head-to-head studies against integrase inhibitors, they're not only not non-inferior, sometimes the integrase inhibitor is superior. And so I think there's real efficacy problems as well with the boosted PIs that may be driven also by their tolerability. Two drug therapies we talked about with dolutegravir 3TC, I think is on the table. It's an option, and we see that with the DHHS guidelines. It's less medication in a pill, so that may be an advantage. Maybe it's cheaper. I'm not sure always that it is. You would think it would cost maybe 2/3 the cost of a 3-drug regimen, but that doesn't seem to always be the case. That's also a very hard thing to get your hands around. There's still less experience outside of clinical trials, so some people have still been a little hesitant, but over time that may change. And for me, it's just a matter of the rationale. I think that there is a good thought about using less medicine. Patients may not care about that, though. They may think, I don't care if I use 2 drugs or 3 drugs to suppress my virus forever. Just do what you think is best. And there's theoretical concerns about long-term toxicity, but we really don't have a lot of data right now that indicate that 2-drug therapy is safer. And again, if the pill is the same size, patients sometimes don't care how many active molecules are inside of it, but some do. TAF versus TDF, again, there's a good rationale for the newer TAF. It has less renal and bone risk. That's why it was developed. It's a smaller pill. It could play well with others and be co-formulated. But on the face of it, whether or not TAF increases weight or TDF decreases weight, same thing for lipids, it doesn't really matter the mechanism. It matters what happens to the person when you give them the medicine, and their scale doesn't care what the operative, pathological mechanism is. It just knows that person weighs more. So again, we have to just think about this. It doesn't seem like it's a huge amount on top of what we're talking about with, let's say, dolutegravir or bictegravir, but I do think it's an issue that sometimes has to be considered. And whether or not we use TAF or TDF, I think more and more, just like in the PrEP space, I think for therapy as well, may come down to cost. So that's a lot of information in a pretty short period of time, but hopefully provides a broad overview of some of the considerations. There's others that we haven't talked about, and hopefully you'll ask questions about that. So thank you.
Thank you so much, David. That was a really superb summary. You gave a very comprehensive, detailed, and incredibly logical review of all of the many terrific treatment options we have. We had lots of questions, and I hope we'll be able to come back to quite a few of them during the roundtable. But now just to deal with one of the burning questions, what about rilpivirine's use in pregnancy? You talked about a number of the other agents, and we know that the NNRTIs have been used quite a lot in pregnancy, but you didn't comment on rilpivirine.
Yeah, and rilpivirine is an interesting drug, and I know that there was some enthusiasm about it also as a 2-drug therapy with dolutegravir. Part of the problem with rilpivirine that's a concern is the levels that you achieve therapeutic, and Dan can talk about this, are just about where the minimum of what you'd want. The formulations that we have now, as you know, require us to eat when we take rilpivirine to absorb more of the medicine, so it's very dependent upon food. And so I think the volume of distribution in a woman who's pregnant, especially in the 2nd and 3rd trimester, makes it concerning to use in pregnancy. So while we have a lot of information about NNRTIs in pregnancy, like nevirapine and increasingly efavirenz, rilpivirine would not be a great choice for a pregnant woman.
Great. Well, thanks very much. Don't go anywhere because we're going to want you back for the roundtable. But right now, it's my pleasure to introduce our next speaker, Dr. Martin Markowitz, who is going to talk to us about injectable antiretroviral therapy. Dr. Markowitz is a graduate of Stanford Medical School and did his postgraduate training in Hem/Onc originally at Cornell Medical College and then in infectious diseases at NYU. He's worked at the Aaron Diamond AIDS Research Center for nearly 2 decades, and actually for nearly 3 decades, I should say, and made some of the really sentinel observations around viral dynamics and many other important contributions over the years. He currently holds positions of clinical director and staff investigator at ADARC and is an Aaron Diamond professor at Rockefeller University. Since the beginning of this year, he was appointed the Anna and George Bobolos Professor of Research in Clinical Infectious Diseases in the Department of Medicine and ID at Columbia University Medical College. So let me give you now Marty Markowitz on injectable antiretroviral therapy.
Good day. It's really my pleasure today to talk about long-acting injectable antiretroviral therapy for the treatment of HIV infection. Here are my disclosures within the past 12 months. Today, we're going to talk about why we need alternatives to daily oral therapy. And I will say that in my opinion, I think we've gone as far with daily oral therapy as we can. We have numerous, very well tolerated, 1 pill once a day options. Along these lines, I will address the first and clearly the long-acting injectable regimen that will soon be entering the clinic, and that's the combination of cabotegravir and rilpivirine. The development of this combination took the form of 1 phase 2b study and 3 phase 3 studies, all of which I will try to discuss over the next 15 to 20 minutes. Please note that I am strictly interpreting the topic I was assigned, so I will not discuss infusible therapy, monoclonal antibody therapy, or some of the newer and exciting potential treatments that are on the horizon. So I think before I start, one thing I've been thinking about is who may benefit from long-acting injectable therapy. And I'm going to, again, take a very strict definition here. I'm going to base my opinion on data that's been generated. And I will give some opinion. And also, as I go through the talk, I'll show you some data why I'm being so careful about some of my definitions. So clearly, there are some people who find it impossible to take oral medications. Some of it due to mechanical problems, such as problems swallowing or problems absorbing. But there are individuals who have been treated for long periods of time, who have done well with daily oral therapy, or just tired of taking pills. And I think this is a very a good patient population who may benefit from long-acting injectable therapy. I think also there are populations that are not experiencing the miracle of antiretroviral therapy. And I'm taking an American-centric view of HIV infection, such as homeless populations, individuals in prison settings where injectable therapy might be very, very useful. And then I'd like to have people just think about the option of packaging antiretroviral therapy with other services, such as social services to the homeless, such as packaging antiretroviral therapy with opioid replacement therapy, or also reaching the hard to reach and the hard to retain populations that are really not being treated effectively at the current time. And here's the data, and I think the data in the United States is really quite striking. We're almost to that 90% target of diagnosed, but we're falling far short of the 90% treated and the 90% suppressed. And one has to ask why. If we're diagnosing near 90% and we're referring most of these people to care, there's a problem with what I perceive as almost perfect daily oral therapy. And that's why we are in desperate need of trying to develop new ways of delivering what I think is the miracle that we've worked so hard to achieve over the last 30 or so years. So really what I like to think of this talk as going beyond daily oral therapy. And as I said, I'm going to focus on long-acting cabotegravir and rilpivirine. I'll talk about those phase 2b and phase 3 randomized clinical trials. And all of them basically use the injectable therapy as 2-drug maintenance therapy. And this will be the first novel delivery modality approved to treat HIV infection. There are some production issues that are being ironed out, and my understanding is that a refiling is imminent, and I am pretty sure that once those production issues are ironed out, this regimen will be approved. Before I go into the nitty-gritty of the efficacy and adverse event profile of this regimen, I do want to talk about some of the things that came out during these studies. It was very clear that there was a benefit of monthly to every 2-month injections. Patients really did enjoy the reduced dosing frequency. And I think it's quite clear that there's a whole change in mindset. Instead of the patients being responsible for adherence every day, adherence to visits become more critical than pill taking. And this is a very critical point. And if we're unable to make sure that patients adhere to visits, then IM therapy may not be ideal. And we'll talk a little bit about that later when we talk about drug resistance. But from a 2,000-foot view from above, in all of these studies, in quality of life questionnaires, patients had a very high level of satisfaction, despite high levels of injection site reactions. Participants appreciated the convenience, the reduced risk of inadvertent disclosure by discovery of medications, and something that came up often was that pill taking is a daily reminder of HIV infection status. And by not having to do that, it improved the quality of their life. Patients also felt that stigma was reduced, but one thing was clear. It was, participants did prefer longer intervals between treatments. So the longer, the better. So let me first talk about LATTE 2. LATTE 1 was a precursor to LATTE 2, but was purely oral and set the stage for this injection-based therapy, so I'm not going to talk about it. But one thing is quite clear about this LATTE study, which forms the basis for the phase 3 studies. All the studies, basically for naive patients, have an induction phase where patients are treated for approximately 20 to 24 weeks with suppressive oral triple combination therapy. And that's very important that we're talking about injectable therapy as maintenance and not as de novo therapy. And there are reasons for that, which are probably a little too complex and too long to include in a 20-minute discussion, but I'd be more than glad to talk about it in question and answer. Nevertheless, after patients were suppressed for 24 weeks, note that 4 weeks of rilpivirine were added just to make sure patients did not have hypersensitivity. Patients were then randomized in a maintenance phase, if suppressed, to 3 arms: long-acting cabotegravir at 400, long-acting rilpivirine at 600 every 4 weeks, long-acting cabotegravir at 600, long-acting rilpivirine at 900 every 8 weeks, or continuation of oral therapy. And this study was carried out beyond 48 weeks to the primary endpoint 96 weeks, and then it was extended. The patients who participated were generally in their mid-30s, which is the age of most patients in treatment-naive studies. Predominantly male, predominantly white, viral loads between 10,000 and 100,000. About 20% or so had viral loads greater than 100,000. And as seen in most naive studies to date, CD4s were healthy, nearing about 500. And note that most of the patients who did take therapy were treated with abacavir lamivudine during induction. A small percentage were treated with tenofovir and tricytidine, probably due to their HLA-B27 status. So, and I want to emphasize this, in this study and another of the patient-naive studies, about 10% or so don't make it from the induction phase to the maintenance phase. There's this loss of about 10%. And most who are lost for during the induction phase are not lost for adverse events, but are lost for what's called lack of efficacy. And generally, lack of efficacy means poor adherence. So we really don't have data in, for example, LATTE 2, on patients who are poorly adherent to oral therapy. And I'll come back to that point later on. Most of the patients, 92.5, made it into the maintenance phase. And then during the maintenance phase, nearly all of the patients completed. And let's look at the data. So for the every 4-week arm, 87% of the patients were undetectable at 96 weeks. Similarly, in the every 8-week arm, 94% of the patients were undetectable at 96 weeks. But I think it's important to note the difference between the two arms. The 13 or so percent of patients where there was no virologic data was mostly due to dropouts due to either adverse events or other reasons. Whereas in the every 8-week, there were more patients who were viremic at the 96-week point. And some of those patients actually did have drug-related resistance, and we'll talk about resistance later on. When the PK was looked at for cabotegravir, shown in green on the left, and rilpivirine, shown in blue on the right, it was quite clear that the cabotegravir PK data was quite tight. But the rilpivirine data in both arms was a little bit suspect. And I want to call your attention to a little bit of an issue with rilpivirine. So the inhibitory concentration 90 is way down here, this dotted line. But the levels that are achieved with the 25 milligram dose of rilpivirine, which is what's used in oral antiretroviral treatment, is about 70 nanograms per ml, and that's here. So it's a little bit unclear what the target should be for rilpivirine in this intramuscular regimen. And therefore, when going into phase 3, it was decided because the every 8-week had more virologic failures and there was some question about the PK, the phase 3 studies that I'm going to show you now had a slightly higher rilpivirine exposure with similar cabotegravir dosing. And they chose the 4-week regimen to take into phase 3. And phase 3 was characterized by 2 studies, the FLAIR study and the ATLAS study. FLAIR was done in treatment-naive patients, and ATLAS was a classic switch study where patients who had been suppressed for a period of time with a minimum of 6 months were randomized to receive either injectable therapy or oral therapy. So let's first talk about FLAIR. So as I told you, most naive studies, mean age is in their mid-30s. The patients were in general male, but there was a good representation of females, about 22 to 22% or so. The study also had a higher representation of Black patients. And so it's really got better demographics than the LATTE 2 study. As most naive studies being done in this era, viral loads were relatively modest, with about 20% of patients having viral loads greater than 100,000, and certainly nearly all, most patients, about 70% or so, have viral loads that are above 350. So very similar to LATTE 2B, 89.7% entered the maintenance phase. And the patients that did not enter the maintenance phase basically were discontinued due to lack of efficacy without evidence of resistance. These patients were non-adherent patients. So I'm going to again emphasize, we really don't have great data on non-adherent patients. We do have good data on patients who are good pill takers. And that's why when I talked about this regimen earlier on, I think it's a good regimen for patients who have pill fatigue, but we don't know whether or not it's a good regimen for patients who are non-adherent to oral therapy. So 283 patients in each arm. Dropouts were similar in the long-acting therapy compared to the continued oral therapy, and I think surprisingly, given the adverse event profile that I'll show you, only 4 patients discontinued due to injection site reactions. So here's the data, and the data is really quite impressive. 93.6% of the patients in the maintenance phase remain suppressed. 93.3% of the patients in the oral therapy remain suppressed. And these data establish non-inferiority of the 2-drug injectable maintenance to continuation of triple combination therapy. There were no difference in groups at sex, viral loads greater than or less than 100,000, and the per protocol population really reflects the intent to treat. Adverse events were common, and I really want to focus on injection site reactions, which are far more common, obviously. There's no injections in the oral arm, but injection site reactions are very common, mostly pain, mostly mild to moderate. Rarely was the injection site pain substantial, and that means greater than grade 3. And as you can see that it was only 11 subjects, 4% of the population. But this is clearly the most common side effect. There are some other adverse events associated with injectable therapy that were not seen in the oral therapy. 1, headache, and number 2, pyrexia. And these are the drug levels in a flare. And again, you can see the PAIC90 for cabotegravir is way down here. And if you look for 2x, 3x, or even 4x PAIC90, the 400 milligram monthly dose of cabotegravir really exceeds that in essentially all patients. Now again, here's the PAIC90 for rilpivirine, and that's 12 nanograms per ml. But if you go back up to the 70 nanograms per ml, that's achieved with the 25 milligram dose of rilpivirine, it's pretty clear that they're not quite meeting that bar in all the patients. Nevertheless, the outcomes are excellent. So it would appear that the PAIC90 is a reasonable target when using rilpivirine as maintenance therapy intramuscularly. And this is the difference between oral rilpivirine use in naive patients de novo, as opposed to rilpivirine use intramuscularly as maintenance. And I think that's an important distinction. And we can, again, talk about that in the question and answer period. So now I'm going to shift gear now from FLAIR to ATLAS. And ATLAS was a classic switch study. Note that the age of patients who are switching are about 7 and 10 years greater than naive studies. And this is a reflection of the fact that these patients have been on therapy for quite a while. Note that most of these patients have been on therapy for a number of years coming into the trial. And that's something important, and I want you to remember that when we talk about some of the resistance data. And again, this study was quite good in recruiting women, recruiting non-Caucasian participants, and as one would expect in a switch study, nearly all the patients have viral loads above 350, and 3/4 of them have viral loads above 500. So they're extraordinarily healthy patients who are selected for wellness and selected for suppression. Note that about half the patients were on NNRTI-based regimens, about a third on integrase inhibitor-based regimens, and about 20% on protease inhibitor regimens. So just to go back now to the patient disposition, remember, we're not talking about naive patients, so we don't have that 10% dropout here. 308 patients did receive long-acting therapy, and 308 patients continued oral therapy. Note that 26 patients discontinued therapy in the injection arm versus 18 in the oral arm, and that's not particularly different between arms. There was slightly more discontinuations due to adverse events in the injectable arm, 4 due to withdrawals due to injection site reactions, 3 due to viral hepatitis, 2 due to headache, and then there were a number of others. What's very striking about this study is the vast majority of patients who participated at the end of week 48 transitioned into the ATLAS 2M study. And that, I think, reflects the fact that patients were very satisfied with their injectable therapy, number one, And the patients who were participating, who were randomized to oral therapy after a year, were very anxious to take injectable therapy. And here are the results. Again, very comparable. 285 or 93% at 48 weeks maintained suppression, compared to 95% on the oral therapy arm. And again, this establishes non-inferiority. I think the difference between the two arms, and I suggested this earlier, was that there was a slight imbalance between no virologic data, with a little bit more patients dropping out due to adverse events or other reasons than patients in the oral therapy arm. And this is not unusual for switch studies. Remember, the patients who are continuing the regimens that they get prior to entering the study, they're used to taking them, and they've been taking them for a long time. So in switch studies, in general, it's the new therapy that has a little bit more AEs and a little bit more dropouts, whether it be oral or injectable. Okay, and back to injection site reactions again. Very commonly, injection site pain in 81% of patients, and the pain was in general mild to moderate and lasted approximately 5 days. So I want to talk about resistance, because resistance is an issue. Now remember, in both ATLAS and FLAIR, patients are selected for clinical trials. So the naive patient study, they select patients who are good pill takers to go into the injectable arm. And in the ATLAS study, they're selecting patients who have been taking antiretroviral therapy pills for years. So they're also good patients. So we're not talking about non-adherent patients. And I want to keep focusing on that, because I don't think the data is there on what will happen with non-adherent patients, number one. Number two, you do definitely see the emergence of drug resistance in patients who have viremia after 48, during the course of injectable therapy. And in the FLAIR study, it's interesting that when the patients do develop resistance, they develop resistance to both NNRTI and integrase inhibitor therapy. And the genotypes are shown here. The phenotypes are shown here. What is very important to note that despite the increased susceptibility documented to cabotegravir, susceptibility to dolutegravir is maintained. And susceptibility to rilpivirine is relatively low level. Now, I do not know the clinical consequences of the emergence of this resistance, but I will say that it's quite clear to me that these patients who fail in FLAIR would be easily salvaged with either a dolutegravir-based regimen or perhaps a bictegravir-based regimen. There's no data yet, and again, my opinion, I want to emphasize that. Notice in ATLAS, where patients have been suppressed for long periods of time, very different population. So the NNRTI genotypes emerge, but 2 out of the 3 don't have anything in the integrase inhibitor. And again, these patients are very likely to be salvaged with effective dolutegravir or bictegravir triple combination therapy. Note that 2 of these 3 patients also had resistant NNRTI resistant viruses in their proviral DNA, suggesting that somewhere along the line, these patients did acquire NNRTI resistance, and this was archived in their proviral DNA and reemerged during therapy. Okay, so finally, I'm going to talk about ATLAS 2M. And ATLAS 2M basically arose out of the observation that the 8-week arm in LATTE 2B was actually performing pretty well over the long term. So Vive went back and did this large again, phase 3 study where they recruited the Atlas patients as well as patients from LATTE 1 and additional patients who could switch. And again, same design. For patients who had never seen cabotegravir or rilpivirine, there's an oral induction. If suppressed, followed by a, these patients are already suppressed, so there's just an oral challenge to make sure that patients are not allergic if they have never participated in an Atlas study or the LATTE study. And then they were randomized to every 8-week or every 4-week drug. Now, notice that they've gone back to the LATTE 2B dosing regimen of 600, 900 every 8 weeks, because it does appear that that PAIC 90 level of rilpivirine is adequate for maintenance. And it's not that 70 nanogram per ml target that one achieves with 25 milligrams of rilpivirine in oral therapy at trough. Very, very interesting. And then there's the every 4-week 400, 600. And these patients have been carried out, and the data were presented this year at the COI meeting. And here are the patients, again, about 500 patients per arm. Most of the patients did not have previous exposure to cabotegravir or rilpivirine, whereas about a third of the patients did. Again, healthy patient population, and remember, all suppressed. And here's the data. The every 8-week, 94.3 at 48 weeks. The every 4-week, 93.5, clearly establishing non-inferiority, and very few patients with evidence of non-response. And these are the patients with no data due to dropout. So in conclusion, I'll say that long-acting cabotegravir and rilpivirine given monthly at 400 milligrams and 900 milligrams respectively provides effective maintenance of viral suppression in HIV-infected subjects. And this has been established by the Atlas and FLAIR study. And these are the data that will be submitted, that have been submitted and will continue to be submitted for approval. So I think the initial approval will approve the 400 milligram, 900 milligram dosing. Now, every 8-week long-acting cabotegravir and rilpivirine given at not 600 milligrams and 900 milligrams is non-inferior in maintaining virologic suppression compared to monthly. And these are the data from Atlas 2M. And these data will also be submitted. I suspect that approval of the every 8-week at that dosing regimen will ultimately also be approved. Injection site reactions are the main adverse event, with mild to moderate pain lasting approximately 3 days. And that's, there's some other minor like headache and a little bit of nodule formation, et cetera. But having done these studies and seen the patients, it's pretty remarkable how well tolerated these injections are. And finally, virologic failure is rare, but when it does occur in a subset of patients, we do see resistance. However, when it does occur, resistance is relatively low level, and it is very likely that these patients will be very salvageable with alternate regimens that can be as compact as 1 pill once a day. So I'll stop there, and it's been a pleasure addressing you today, and I'm anxious to take your questions. Thank you.
Well, thanks, Marty. That was really an excellent talk and really exciting new information. I'm sure everybody is looking forward to see how these agents are going to be used. We have time for only one very brief question. So you touched briefly on this point, but maybe you can say a little more. For the patients who do experience a virologic failure on an injectable, How confident can we be that alternative regimens are going to be effective, particularly if there is emergence of resistance to cabotegravir and rilpivirine as a consequence of failure?
Well, you know, from what we can see so far, the resistance test would suggest that second generation integrase inhibitors like bictegravir and dolutegravir maintain susceptibility. It depends really on their history of whether or not they've had resistance or, you know, breakthrough to other NRTIs. But based on the data that we're seeing, my sense is that these patients will be eminently salvageable with a 2-nuke and third generation integrase inhibitor. The other very exciting drug that's coming up is EFDA, or is latravir. And that is another drug, hopefully, that we'll be able to use in the future. And that's a drug that has fantastic activity in patients with NRTI resistance, and a combination of a second generation integrase inhibitor plus that drug would be fantastic salvage regimen as well. So I think there's a lot. And the Gilead, of course, there are other drugs, long-acting drugs coming, like the Gilead maturation inhibitor. So I think there's a lot. Capsid inhibitor, sorry. There's a lot in the pipeline.
Great. Well, a lot to learn still. Let me remind all of our audience that you can send in your questions using the Q&A function in Zoom, and we're collecting them and going to be getting to all of them, or as many as we can, during the roundtable. So let's move on now to our next talk, and it's my pleasure now to introduce Dr. Michael Kozal. Dr. Kozal is a clinical and translational researcher who has focused his research on 3 important areas in HIV and HCV, pathogenesis and treatment. He's been really key in investigating the genetic determinants of resistance for drugs treating both of those viruses. He's been at the forefront of the development of new molecular methods to detect viral mutations, and has engaged in HIV and HCV clinical trials involving new drugs and diagnostic technologies. Dr. Kozal is an expert in microarray and deep sequencing technologies, having been involved in some of the very earliest efforts at developing those and applying them to genotyping for patient care. He previously directed the Yale HIV Clinical Trials Group and has more than 25 years of experience in running over 40 HIV and hepatitis C trials. He's served on multiple review panels for the Veterans Affairs Administration, as well as for the NIH and NCI, and is currently a member of the DHHS NIH panel on antiretroviral treatment guidelines for adults and adolescents. Today, Dr. Kozal is going to talk to us about advances in the treatment of highly antiretroviral therapy experienced patients with HIV. Michael?
Well, thank you, everyone. I'm glad you were able to join the conference. I'd like to start with my disclosures. These are my disclosures. I am a member of the NIH guidelines panel, but the opinions I express today are mine alone. So I'd like to start with a case. This is a typical highly treatment experienced patient that was referred to me. He was a 52-year-old that had failed multiple prior regimens. He had active thrush and presumed esophagitis. He also had zoster of the palate and AVN of the hip. His CD4 count on therapy was 2, and his viral load was 22,000 on therapy. But off therapy, his viral load would rise up to 500,000. His current regimen was darunavir, elbitergovir, cobicistat, FTC, and tenofovir. A combined genotype and phenotype resistance results showed that he was resistant to all oral agents except integrase inhibitors, and he refused T20. So in your practice, depending on where you practice, roughly about 3 to 5% of your clinic population probably meets the criteria of a highly treatment experienced patient, and I'd like to talk about them today. So a typical highly treatment experienced patient also has many other complex factors that factor into when you're making a decision on what regimens are best for such patients, such as adherence factors, comorbidities, unstable housing or psychosocial issues, interruption of ART. Many have had drug adverse effects or prescription errors, and also complicated dosing regimens. In addition, many of our patients have comorbidities, and I can't go through all the conditions listed on the left-hand side of the slide here today, but I encourage you to download the NIH app, as each one, within this guidelines, they actually address each one of these situations and make a nice recommendation of what regimens might be best to use in such situations. Often, many of our patients that are highly treatment experienced are over the age of 50, which can add to complexity of the ART decisions. They more frequently have drug adverse events, and they also have many concomitant drugs that can often be used in the elderly. And these actually can make it very difficult to actually choose a good regimen. We also have to monitor patients' bone, kidney, metabolic, and cardiovascular and liver health quite closely after starting a regimen. Polypharmacy is also common in older patients, and it increases the risk of drug-drug interactions. And drug-drug interactions, you can get lower drug levels, increased drug levels, and all these can lead to adverse effects if we aren't careful. What about HIV-related factors in such patients? Well, many of them have failed multiple prior regimens, so they actually have complicated resistance patterns that you have to deal with. Also, some of them have acquired drug resistance. Some patients can have innate resistance to specific ARVs due to viral tropism or the presence of HIV-2 infection. And higher pretreatment viral load does actually affect some of the regimens that we might use in such patients. What about drug-specific factors? Well, suboptimal viral pharmacokinetics can occur, and you can get variable absorption, metabolism, decreased penetration in sanctuary sites. Many of our patients have been exposed to suboptimal viral potent regimens because they've lived a long time, and they were exposed to the early NRTIs, the unboosted protease inhibitors, and some of the earlier integrase inhibitors. Many of these regimens had reduced efficacy, and some patients were actually exposed to monotherapy or dual therapy. I have many patients in my clinic that actually started treatment in the early 90s, and they had suboptimal regimens at that time. And some of our drugs actually have a lower genetic barrier to resistance. So I commonly get asked about highly treatment experienced patients, and this is a typical scenario. I have a patient who has A and B comorbidities, resistance to X, Y, and Z different ARVs. The patient has failed 2 prior regimens, and the most recent report, I only have one of them, as the patient has come from out of town and didn't have their medical records. So the patient only wants to take 1 ART once a day, and was thinking, the provider will say, I was thinking of using X, Y, and Z ARVs. What do you think? And the easy answer is always to say, have you thought about a clinical trial? The harder answer is, you can try that combo that you're considering. However, it's not been formally studied in this situation. We should get some more info. And I commonly get asked by the provider, why hasn't this regimen been studied? What other labs should I get? Well, one of the reasons why most combination therapies and very advanced, highly treatment experienced patients haven't been studied is just that we have a lot of choices that we can choose from. Currently, we have 7 drug classes with over 29 different agents that we can combine into a regimen to treat a patient. And just to show you the complexity of the possible combinations, I'd like you to think about desserts. Imagine choosing 3 desserts from a menu that only has 10 items. How many possible different combinations do you think you could put together with that? Well, the math majors could tell you that it's quite large. There's over 100 possible different combinations you can make of 3 different desserts from an item of 10. So imagine if you have 20 different agents that you're trying to possibly put together to do it for a treatment experienced patient. That's over 1,000 possible combinations. And why that's important is only a limited number of combinations have been formally evaluated in a clinical trial. So often we're putting drugs together that have not been formally studied in a randomized clinical trial. So we have to monitor our patients very closely because of this. But luckily, we have a lot of good tools that we can use to actually understand the HIV variants infecting a highly treatment experienced patient. And I'd like to walk through some of these tools. So the first is resistance testing. And resistance, you should get a resistance test anytime a patient is experiencing virologic failure, such as greater than 1,000 copies, or if the viral load is between 500 and less than 1,000 copies, a resistance test should be obtained if a patient is on a failing regimen. And recently, the International AIDS Society and USA panel has come forward and suggested that if you've had persistent viral loads greater than 200 but less than 500 copies, you can attempt a drug resistance assay in such patients, although it may not be successful. And obviously, if you started a patient on therapy and you've had a suboptimal viral load reduction, and you've had 2 consecutive viral loads greater than 200 after 24 weeks of starting therapy, you should evaluate the patient with a resistance assay. So I heard that there might be some in the audience that are relatively new to HIV treatment decisions. So I wanted to talk a little bit about genotypic resistance testing. These assays, actually, how they work is we amplify gene regions which encode the viral proteins and enzymes that are the drug targets, and we look for mutations within those viral genes. And each one of those mutations that we identify is actually given an algorithm weight, depending on how much they can affect the drug susceptibility. And then we use algorithms to actually calculate if the virus is resistant or not. And why do we need to use algorithms? Well, these assays screen for over 100 different mutations, and so that's a lot of possible combinations that need to be adjudicated. So when you're doing a resistance assay in a patient that's failing therapy, drug resistance testing should be performed while the patient is taking the failing regimen or within 4 weeks of treatment. And why that is this is a figure we did from a review. And if you see these red little squiggly lines, they're supposed to represent drug-resistant virus. But in the absence of drug pressure, wild-type virus will outcompete the drug-resistant virus and overtake the population in a patient that's off therapy. And once the viral load gets, once the population of the resistant variants fall below 20% of the circulating population, standard Sanger-based sequencing may not detect these variants. However, if that person's put back on that same regimen, the resistant variants could rapidly reemerge and cause treatment failure. However, even if more than 4 weeks have elapsed since the ARVs have been stopped, you can go ahead and attempt a resistance assay. However, you just need to know the caveat that it may not be detecting all the possible resistant variants that are there. So a genotypic test is preferred over a phenotypic test to guide therapy, especially in patients on their first or second line regimens that they're failing. However, a phenotypic test can be added to a genotypic test if you suspect a very complicated resistance pattern. And phenotypic test basically measures the ability of the patient's virus to grow in various concentrations of the drug. The ratio, and it's usually reported as the ratio of the IC50 of the patient's virus versus a reference virus. And then it's reported as a fold change compared to the reference virus. And these can be very helpful in determining what agents you might be able to use. But I encourage you to work with a specialist in this area if you aren't very used to using phenotypic assays. What about tools to evaluate tropism? Well, HIV entry involves the sequential attachment of the virus to the CD4 cell receptor, and then it either engages the CCR5 co-receptor or the CXCR4 molecule. And this leads to viral fusion of the viral envelope and cellular membranes. Now, we have drugs that actually can block that binding on the CCR5 receptor. And to determine if the virus would be susceptible to these agents, we can use HIV tropism testing. We have these for both HIV RNA and proviral DNA, which I will talk about in a little bit. And you can either use a phenotypic recombinant virus assay or next-gen sequencing of the V3 region of the virus. And then we use bioinformatics to predict co-receptor usage. So I want to take a moment and step back and just talk about proviral DNA testing. So with these assays for resistance or tropism testing, basically we're evaluating the archived proviral DNA in a cell. And when we do these assays, they typically require about 4 milliliters of blood, and then you're extracting the peripheral blood mononuclear cells from the whole blood. But CD4 cells only make up about 25 to 50% of the population. And in a patient that's virally suppressed, you might only have 4 or 40 proviruses that are sampled in that test. And why that's important, in a virally suppressed patient, only about 1 to 10 intact proviruses are in a million cells. So you might be really only just getting a very small sample of the resistance burden in these patients. And so that will become important in the next few slides. So this is a figure from a review we did a while back, but I've updated it. And it's basically the management of highly treatment experienced patients. So if you have a person on therapy and they experience viremia, the first thing you should do is assess adherence. You should look for drug-drug interactions, drug-food intolerances, and any patient comorbidity that might be affecting their adherence. You should evaluate the HIV viral load and CD4 cell trends over time. And importantly, you need to get all prior ART history and prior and current drug resistance assays and consider a tropism test. And you should use all these histories and prior resistance assays to basically understand the cumulative resistance burden in the patient before constructing a new regimen for the patient. And then the most important principle is when you choose a new regimen, it should include 2 and preferably 3 fully active agents. And obviously get expert advice if needed. So back to proviral DNA genotyping. This is relatively new, but these assays may be used in patients with HIV RNA below the limit of detection or with low-level viremia where HIV RNA genotypic assay may be unsuccessful. They can also be considered for in patients who are experiencing virologic failure for whom conventional genotypic assays are unavailable or unsuccessful. But you need to remember the results should be interpreted with caution as these assays might miss some or all the prior drug resistance mutations. So they're helpful if they identify some additional mutations, but if they don't identify anything, you still need to use the whole patient scenario and history to understand what would be the best regimen for the patient. So what if the patient comes to you and they're off therapy? This is not unfortunately, it's not an uncommon situation in our clinic. So a patient, if it comes to you off therapy, you should try to get all the prior HIV assessments and ART history. Proceed with getting an HIV genotype and viral load and other virologic assessments. And then start 2 and preferably 3 fully active drugs for the patient. However, if the prior genotypes aren't available and there's only drug-sensitive assays on the genotype, you can restart the last regimen the patient was on and then follow them very closely within 2 to 4 weeks, reassess them to make sure that they're experiencing benefit from the new agents. So in general, the most important principles for caring for a highly treatment experienced patient is, in general, adding a single agent to a failing regimen is not recommended. This may risk the development of resistance to all the drugs in the regimen. Some ARVs may be partially active against HIV, and you can still retain those in the salvage regimen if needed. For some heavily treatment-experienced patients with a heavy burden of resistance, you may not be able to suppress the virus. However, ART should still be continued in such patients to minimize toxicity, preserve CD4 counts, and delay clinical progression. ART should not be stopped in these situations. Many studies have shown that this would increase the risk of disease progression. So if it's not possible to construct a suppressive regimen for a patient with multi-drug resistant HIV, I encourage you to consider a clinical trial of investigative agents. And young HIV providers that are just starting in the field, I encourage you to establish a network with clinical trial groups so you can get access to clinical trial drugs. Below are just some examples of 4 different categories of drugs that have new mechanisms of actions that are currently in clinical trials. I don't have time to go through those today, and many of you may not have access to those drugs. However, I do want to speak a little bit about iberdomide and fostemsavir, as these are already available in some areas, and soon will be available, I think, widely. So iberdomide is a post-attachment inhibitor. It's a non-immunosuppressive monoclonal antibody that binds to the CD4 cell receptor, preventing HIV entry into the lymphocyte. My colleague, Brenda Emu, here at Yale, actually reported these in the New England Journal. And when iberdomide was given with an optimized backbone therapy, approximately 43% of the patients had a non-detectable viral load at week 25 after starting therapy. So it is a new option for patients. It is an IV drug, however. We recently reported on fostemsavir in the New England Journal a couple months ago. Fostemsavir is the prodrug for temsavir, and it binds directly to HIV-1 GP120 and prevents the viral attachment and entry into the CD4 cells. And those of you that have access to New England Journal, I encourage you to go to this article, and we actually made a video summary of the mechanism of action of this drug, so you can watch it, and I think it's well done, and it helps people understand how the drug actually works. So these are the data from the study. They're the virologic and immunologic outcomes in the observed analysis at week 48. And as you can see in the upper left-hand panel, panel A, roughly 60% of the patients had a non-detectable viral load out to week 48. These were patients that were given fostemsavir and then were given, in addition, in the optimized backbone therapy, at least one, but no more than two other active agents. And you can see up to 80% of the patients had a non-detectable viral load less than 200 copies at week 48. In the non-randomized cohort, which is in the right panel, upper right panel, these were patients that had no other options available. So basically, they were given fostemsavir monotherapy. A few of the patients also got iberdomide in the trial, but most of the patients, fostemsavir was their only active agent. And you can see roughly 50% of the patients had a non-detectable viral load at week 48 in the observed analysis. And the CD4 counts were actually were very good in these patients in both arms. So that's what we chose for our patient that I began this talk with. We chose fostemsavir twice a day with dolutegravir twice a day. Remember, he was sensitive to dolutegravir, and we continued darunavir for the patient. The patient initially developed IRIS when this regimen was started. He had a very nice viral load drop, but we uncovered PML in the patient. However, the patient continued on the regimen, did extraordinarily well. His PML basically stabilized and was no longer active. And out to almost 3.5 years, the patient has continued to do very well with the CD4 rising to above 200. And you can see his viral load never went all the way down to non-detectable, but he continues to benefit from the drug. So in general, caring for patients with drug-resistant HIV, the goal of treatment should be to resuppress the viral load to non-detectable levels. You should change ART as soon as possible when you have available regimens for the patient that would likely be effective. And virologic responses to the new agents are likely to be better if the viral load is lower and the CD4 count is higher. And the new regimen should include 2 and preferably 3 fully active agents. And a fully active agent is defined as a drug that is expected to have uncompromised activity based on the ART history and past and current resistance results. And a fully active agent may also have a novel mechanism of action, and I strongly encourage you to refer your patients to clinical trials if they're available to you. So I just want to drive home the last point. Use all prior and current drug resistance results, if available, when you're constructing a new regimen for a patient. So I'm going to stop there. I know we're going to have time for question and answers, and I really appreciate you all attending. Thank you.
Well, thanks very much, Mike, for that terrific talk. Really complicated patients that requires special expertise in knowing how to manage, and you did a superb job of summarizing all the essential information that we need to manage these patients. Let me invite my fellow panelists, Marty Markowitz and David Wohl, to rejoin at this time. Unfortunately, Dr. Kozal isn't going to be available for the panel. So I'll just ask one brief question of myself that was raised in our Q&A box around use of proviral DNA genotyping for resistance testing. And, you know, I'd have to say that the data are still not all in. Clearly, there are good correlations between proviral DNA testing and testing of plasma virus, but we know that a lot of the proviral DNA is in fact defective. I think it's safe to say that if you find a mutation in proviral DNA, it is probably significant, but the failure to detect a mutation may be due to the relatively low frequency of proviruses in circulating cells, and there's no guarantee of their absence. And clinical data have been sort of mixed or absent on the overall clinical utility of that test. So let me turn now to back to Dr. Wohl and ask, you know, you covered some really important information about weight change in people initiating antiretroviral therapy. How do you factor in a patient's weight or their body mass index in deciding what's an appropriate regimen for your patients?
Yeah, I think some of the data that we're seeing emerge over the last year has been very helpful, and I'm sure at this conference we'll see a lot more. So the answer could change a week or two from now. COVID is not the only dynamic field of inquiry, and this is one of those that I think in HIV is sort of at the cutting edge. For me right now, I am struck by some of the data we're getting, not only from Africa, but also some from here in the US. And ACTG, Dan, as you know, has done some really great analyses looking at people who switch therapy to integrase inhibitors, and I think have found very much under Jordan Lake and others' guidance that there is this, this factor of being female and being a female of color, and that really concerns me. And so I think, you know, less for the thin white woman, am I really worried about this as much? I counsel everyone this could happen if I was going to start or switch to bictegravir or dolutegravir. But I am really cautious, especially about a weight-conscious person who is African-American, especially if it's a woman. So I really have to tell you, this is becoming more and more of a factor in my decision-making.
Yeah, thanks. I think those are really important considerations. I'll go back to a comment that was made earlier in the Q&A box around whether or not the intersection of HIV and COVID-19 is causing increased adverse outcomes. And the person who raised the question noted that in South Africa, there was some data emerging that there might indeed be an adverse interaction. I think that would be consistent if it turns out to be to hold up with a larger and more systematic study. It would be consistent with what we've seen with influenza, where we know in lower middle income countries, especially people with advanced immune deficiency from HIV, that there can be worse outcomes, but not so much in people with better preserved immunity. Marty, sticking with the lower and middle income countries, you may not have an easy answer for this question, but one of the concerns raised is how accessible are injectables going to be for people in lower and middle income countries where they really have potential to have enormous impact around adherence, and we're not even talking about their potential role in prevention.
You know, Dan, that's a great question. Sadly, I don't work for ViiV, so I don't work for ViiV. It's not so sad necessarily, but I can't answer that question per se. But you know, when I started thinking about these injectables quite a while ago, my vision was to kind of think a bit out of the box, and especially in areas that I visited in Africa, what was always striking to me is how difficult it is for people to get to treatment, and often have to walk long distances or drive long distances. And it would be so fantastic if healthcare and HIV care could be packaged with other care and actually delivered to people, so that instead of people coming to the mountain, or people going to what they the healthcare really coming to them. Mm-hmm. And I personally think that this is going to be the future of injectable therapy for both prevention and treatment in the developing world. And I really hope that it's priced or distributed in a way that that miracle of antiviral therapy can be extended, because that's really what we're talking about. Because we know we have incredibly effective regimens, but we can't reach everyone, obviously. And we've been trying to do this for a long time. So we have to really take our thinking and be outside that box and do things differently. And I think that this is going to be able to do that.
And another difficult question for you. You mentioned the potential important role that injectables could have in prison populations. How would you balance, what could be a coercive aspect of insisting that prisoners agree to injectables if they want to receive antiretrovirals versus providing choice? There are obviously some big advantages of injectables. You don't have to have pills every day or let other people in the prison know necessarily about your status.
Right. And I think that from that point of view, I don't work in prisons. My only exposure to prisons is way back when I was a fellow at Bellevue, and we would go into the prison unit at times, and it was a difficult place to go. I can only tell you that long-acting injectables are really preferred by the patients. And obviously you cannot coerce anybody to do anything they don't want to do. And certainly giving people that option in a setting such as prisons could be highly desirable, particularly as far as stigma, et cetera. I think it would make if I've always found that people will do what you want. What people will generally make a decision if things are presented in a way that makes sense for them. So I think that if injectable therapy is presented in a way that makes sense for people in that institutional setting, perhaps the uptake will be good.
Yeah, Dan,
packaging those therapy. I'm sorry, Dave.
No, I thought you were done. Sorry, my bad.
No, go ahead.
Yeah, so I've worked in prisons a long time, and I think Marty's right. I do think that there's other examples. There's antipsychotics or birth control that can also be given for various reasons, not for necessarily contraception, but that there's injectables. I do think there's always a risk of coercion, but I'll tell you right now, oral therapy is not without its problems in prison as well. And sometimes there's stockouts or long lines. If it's directly observed, it's still done. So I think this could be a solution. The other thing to think about is creatively, can you give someone an injection and then release them from prison, buying them time to link to care and get on therapy? Because a lot of folks break down as far as being able to stay on their medicine or get access to medicine. So especially if we're looking at an every 8-week injection, bridging could also be another use of this, but with the right setup, because you don't want low levels dissipating over a long period of time, as Marty pointed out.
Right. I think that's really critical. But, Dan, the other thing I wanted to say is we need to get creative about how we deliver healthcare, perhaps package it in a wellness package instead of this disease model, because there are people that we're clearly not reaching. And if we could package social services with healthcare, perhaps uptake would be much better than having these silos and where we're not being as effective as we should be, or we could be.
Great. Well, we're going to have to wrap it there, I'm afraid. We had lots of questions that I'm sorry we don't have time to get to, but this has been a terrific set of talks by David and Marty and Mike, and good discussion. We're going to now take a 6-minute break, returning at 2000 hours European time 1400 hours or 2 p.m. Eastern Daylight Time and 11 a.m. Pacific Daylight Time for the second session that will be moderated by Sharon Walmsley. So thank you all for your attention, and you can now stretch your legs, get some coffee, attend to your emails, and hope you enjoy the rest of this global forum.
Stay safe. Thank you.
Thanks, guys. Bye-bye.
Take care.